Dr. Parak sir, good evening and welcome. Dr. Vavikar, welcome.
Good evening.
Good evening, sir.
Hello, everybody.
Hello.
Hello.
Hi.
Hello, sir.
Hello.
Anjali,
Yeah.
I can see Dr. Parak's name. He is joined in, I think.
Yes, yes, sir.
Yes,
Sir, do you want to?
Yes. Dr. Parak,
Do you want to try sharing your screen, sir? Good evening, sir. Parak, sir.
sir, unmute yourself, please. Parak sir, you need to unmute yourself.
Yeah, now audible now?
Yes, sir.
Yes, sir.
Good evening, sir.
Yeah. Good evening.
Good evening, sir.
Good
So would you just
evening.
like to share your screen once? Before we start, just as practice.
Now it is seen.
No,
No,
sir.
sir, not yet.
Is there na in on the top with others? I can see it.
Sir, you will have to press the up arrow at the down of Zoom app. Green colored up arrow. Share, saying share.
Share screen
Ah.
is written.
So you will get multiple options there, sir.
There are entire screen is one option.
Yeah, sir, you can open your PPT in the background and select that particular option. You can
Okay.
minimize this app and then open your PPT in the background and again you can try, sir. Yes,
Is
sir.
it seen?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir.
Okay. Thank you. Great.
Very nice.
We are able to see and hear you properly, sir. Thank you.
I am not very good at these technical appliances.
Okay. Now
But I'm also sailing in the same boat.
are we good to start?
Is it time?
Manisha,
Yeah,
6:30.
I think we can start, no?
Yeah.
Good evening, everybody.
Good
It
evening.
gives me great pleasure to welcome you all for this webinar on anesthesia and ophthalmology, a topic very often not included in the normal anesthesia conferences. About 2 years back, when I was going through an anesthesia WhatsApp group, I happened to come across a brochure of a conference of anesthesia and ophthalmology. It was at that time that I realized that there is a separate association of ophthalmic anesthesiologists. The idea of having a webinar for Thane Anesthesia Society came from there only. As luck would have it, a couple of months back, Dr. Reena and I were traveling in the same Uber from a conference. And I broached this topic to her, and immediately she got very excited. And hence, here we are today with this very unique webinar with great speaker and guests. I welcome all of them for this webinar. Our chairperson for today's webinar is an ophthalmologist who will give us great inputs from the surgical side. Dr. Chandrasekhar Vavikar is well known to all in Thane and is a legend in eye surgery, having received training from the best centers all over the world. He has many firsts to his credit. He was the first one in Asia to perform a true laser bladeless cataract surgery. He was the first in India to do wavelight plus LASIK. And he was the first to start an optometry college in Thane district. His Vavikar Saurabh toric calculator is one of the top 15 ophthalmic innovations. A recipient of many awards and accolades, he has recently received a gold medal for his exemplary work in the field of ophthalmology by the BOA. It is therefore no wonder that the Chief Minister of Maharashtra chose Dr. Bhavekar for his own cataract surgery. I extend a warm welcome to Dr. Bhavekar and all of you again. I now request Dr. Parna Thakkar to take the program ahead. Thank you. Dr. Parna.
Good evening, everyone. Happy World Anesthesia Day to all. Thane ISA has already begun the World Anesthesia Day celebration activities by starting the celebrations last week. So last week, we gave donation to the transgender organization, which is run by Yoga Devi. We also gave donation to an old age home. COLS activities were performed at Rajiv Gandhi Medical College, and we trained Maharashtra Security Force on Sunday at Rajiv Gandhi Medical College. Also, 300 packets of biscuits and chikki were distributed to the pediatric and maternity patients at Rajiv Gandhi Medical College, and it was truly, truly a very satisfying experience going to the medical college and giving sweets and biscuits to the children and the pregnant ladies. We enjoyed it. Yesterday, our members celebrated World Anesthesia Day by doing various activities. COLS and anesthesia awareness activities were performed. Also, cake cutting was done at various hospitals. I gave a program about anesthesia awareness at on FM radio 92.7 Big FM, and it was aired in the afternoon. It was about anesthesia and anesthesiologist awareness program, and it was well received and appreciated by everyone. Also, we are planning to give donations to Kshamta Orphanage, and today we've kept this webinar specially to celebrate World Anesthesia Day with all the Thane ISA members and Dr. Vaishali Bhavekar, who's the chief editor of our newsletter, Samvedna, will be releasing the newsletter, which has come up very well. And every quarterly, we release this newsletter, and it has all the activities about Thane ISA. And it's a pleasure to introduce Dr. Vaishali Bhavekar. She and Dr. Bhavekar, her husband, they both are very close friends. And she's the backbone of Bhavekar Eye Institute. And due to her efforts, her small clinic has now got transformed to a state-of-the-art eye institute. And you've already heard about Dr. Bhavekar. She's an artist, dancer, a very good dancer, and she's performed at various ISA programs, and she's a writer, and also she studied psychology. She's working for many NGOs and is actively involved in social welfare activities. I welcome Dr. Vaishali Bhavekar to release the newsletter Samvedna. Unmute. Unmute.
Madam, you are muted.
Yes. Very good evening to one and all present here. Thank you very much for the kind introduction, Parna. With immense pleasure and pride, I present to you the 8th edition of our bulletin, ISA, Thane ISA Bulletin. It is named Samvedana, in the esteemed presence of our guests, Dr. Parat, Dr. Reena, Dr. Aruna, Dr. Manjula, and Dr. Bhavekar. This bulletin is basically the mirror of all the diverse activities which are undertaken by our members, and it shows that anesthetists are not only good at their work, but they are coming up, they are making mark as philanthropists, as artists. They are very active in social and cultural fronts. So it's a very nice to compile all these activities and present it to you. Thank you so much. Anjali, can we have the glimpse of the bulletin?
Yes, ma'am. This is the ribbon.
Wow. Happy World Anesthesia Day to all.
Yes, happy World Anesthesia Day.
It's a pleasure to see Veena here, and she's also a very close friend.
Madam, is it seen now?
No, Anjali.
Samvedana?
No, not yet.
No, not seen.
Okay. Now?
Yes.
It's come out very well, Vaishali.
Thank you so much. Yeah.
So we will be sharing it on all the WhatsApp groups also. So
Yes.
everybody please go through it and give us your feedback.
Yeah, please. Very nice.
I just wanted to tell
Anjali,
one
just
thing.
quickly scroll through it. Anjali?
Yeah.
I just wanted to say one thing that here there are three people whose husbands are ophthalmologists. So Vaishali, me, and Veena. So
Aruna madam also. Madam
Aruna,
also.
Meenal.
yes, yes.
We have many in Thane.
I'm just scrolling
Email is
for
there.
everyone.
The workforce well-being was the theme of this bulletin actually, and then we have tried to include some articles about that. And our members are really vibrant and radiant under the leadership of Dr. Manisha. So the bulletin is very colorful. We are multi-talented people in this organization.
Absolutely.
Another
It just shows
highlight
that
is
our
the
branch is active on all fronts.
yes. Another highlight is the protest which all our members took part actively in Kolkata doctor case. So that was a maximum participation from anesthesia department.
Regarding this matter, I would just like to make a small request to everybody that everybody flood your Twitter if you're on Twitter with a message in support of this RG car mishap, and we will share it on all the groups. So you can share it on your Twitter and make the authorities and the official persons awake about what is happening and that justice has been denied for too long and high time to take charge of it. Thank you, Vaishali.
Thank you so much, everyone.
In fact, yesterday in our Anesthesia Day celebration, we had a panel discussion on atrocities on women in workplace. And we had a lady police officer, lady advocate, and an anesthetist as panelist.
Yes.
Dr.
Anjali, you can
Dev
now
Divan
start
has
the
also
scientific
joined.
program.
Welcome, Dr. Divan, sir.
Welcome, sir. Am I audible?
Thank you so much.
Yes,
Thank you
Anjali.
very much.
Yeah. Good evening, everyone. Myself, Dr. Anjali Nair. I welcome you all on behalf of ISA Thane for yet another interesting scientific session on anesthesia and ophthalmology. Ophthalmic surgery is currently the most common procedure among the elderly population. And even though these procedures are considered as low risk, the extreme age group with significant comorbidities present unique challenges to us. So we have esteemed speakers on our platform today, sharing their expertise. To talk about perioperative do's and don'ts in high-risk ophthalmic cases, we have none other than the founder, president of AIOA, and consultant anesthesiologist at LV Prasad Eye Institute, Hyderabad, Dr. S.C. Parak, sir. Welcome, sir. Sir is presently the president of Family Benevolent Fund of ISA. He has been secretary, vice president, and president of ISA Andhra Pradesh State. He has also been ISA National Vice President. I request sir to give his valuable insights on this topic. Sir, I will stop sharing the screen, then you may start sharing. Sir?
Yeah, 1 minute.
Yeah.
So, am I muted or?
Sir, you are audible. Only thing,
1 minute.
yeah, you are audible, sir.
1 minute. So I welcome everyone to this session on ophthalmic anesthesia. In the beginning, I request all the participants who are here because they are interested, they are here because they are interested in ophthalmic anesthesia. So I request everybody to join this AIOA, Association of Indian Ophthalmic Anesthesiologists, so that they will regularly get our e-journal also and they can participate in our activities. And I would like to bring out that this is not only for anesthetists. Our rules are that anyone who is involved in eye care, he can become our member, whether it is a surgeon, anesthetist, technician, nurse, even if some NGOs are working for eye care, everybody can join it. So I request that please become member of AIOA so that your interest in ophthalmic anesthesia will be taken care of and you get regular information and updates. Now, this is my institute where I am working, LV Prasad Eye Institute, one of the premier eye institutes of the country. Now, when we talk about high-risk cases, so there are high risk for surgery and high risk for anesthesia. And there are
Sir, your
some
slides
cases.
are not
Sir,
visible.
yeah, sir, sorry
Hello?
to interrupt you. Do
Your
you
slides
want
are not
to?
visible.
Yeah, you are not. We are not able to see your presentation, sir.
Then in that case, please
You want me to share? Okay, sir.
let Anjali do that.
Yes, sir.
Don't worry, sir. Anjali will share it for you. Don't worry. Sir can share, Anjali.
But it's not visible, you said.
No, no, now it is visible, sir.
This is sir's screen.
This is sir's screen and now it is visible. Yes, sir,
Is
it is
it okay
visible.
now?
Yeah,
Yeah.
yeah.
So that high risk is maybe for high risk for surgeries. What is they call it as guarded visual prognosis, and high risk for anesthesia. And there will be definitely some cases who are high risk for surgery as well as for anesthesia. So I will only talk about what is high risk for anesthesia. Now, one thing we should all realize when we are dealing with ophthalmic surgery, that nobody expects a mortality in ophthalmic surgery. So expected and accepted mortality in ophthalmic surgery is zero, because we are not doing any life-saving surgeries. So it is not justified to risk a life. So this we should always keep in mind. And if there is any risk of life, we don't attempt to restore vision at the risk of life. So we should always consider this, because later on people will blame. Always a living person is better. Living blind person is better than dead. So although we say that all must see, but it is not possible that everybody will see. So first thing we have to do is, I come to do then don'ts. So we have to assess the risk factors, optimize those risk factors, discuss with surgeon, patient and relatives in detail, And then only we proceed for anesthesia and surgery if we feel that life is not at risk. The patient's other systems are adequately working to bring him through the anesthesia and surgery procedure. If there is any doubt about that, then we don't attempt the eye surgery. Second thing is no general anesthesia for whatever can be done under local anesthesia. Because all said and done, every general anesthesia procedure carries some risk. Even in healthy people and minor procedures, we have seen that patient get into complication. So there's no point in taking risk of general anesthesia if the procedure can be performed under local or topical anesthesia. Then there is a very small thing. Loose teeth is a very minor thing, but it can be fatal. And we should always, during our PSC, we must assess if the person has got loose teeth. We say missing teeth also, but missing teeth will create difficulty in intubation, but it cannot be fatal. But loose teeth, if it drops and goes into airway during laryngoscopy, it can be fatal. So we should be very careful about it. And in a PSC, this should be recorded that this patient has these loose teeth or these missing teeth or artificial crowns, because dental treatment is very costly nowadays. And if we break the crown during our laryngoscopy, the patient can be, he can ask for compensation also for that matter, because he has to get a fresh crown. So we have to be very careful about the teeth. Then risk factors are comorbidities, whatever, most of them elderly people will have hypertension, diabetes. This hypothyroidism is very common. And some of them will have respiratory problems also. Then if they are consuming alcohol, there may be liver problems. Then age-related problems, because systems in body are compromised as the age grows. So, and then we take a previous history, whatever surgeries he has undergone, general anesthesia or ophthalmic surgeries under local anesthesia. If there are any allergy, because anaphylactic reactions we have seen in ophthalmic anesthesia, history of smoking and feeding, because fortunately we are not doing such emergency surgery that we have to take a full stomach patient. We can always wait, and eye surgeries can give us some time that we wait till the stomach is empty for the patient. Because in eye surgery, there are general surgery, many times we may have to take the patient with full stomach also, but in eye surgery, there is no scope for that. So we must always see that fasting, pre-op fasting instructions are followed very religiously. Then personal and family history. Fasting is not just pre-op fasting and post-op fasting. Both are very important, because if early feeding in the post-op period may cause aspiration and deaths have been reported in. Hello?
Optimize comorbidities कोई नहीं वेट करेगा.
So, if surgery is elective, for example, cataract surgery, even it can be done after 2 or 3 months. So then we can even advise them to stop smoking, reduce the weight if they are very obese. Then dental consult and optimize everything, whatever can be done. And there's no harm in taking help from our physician, cardiologist, respiratory physician colleagues, because nowadays I hear a lot of fight about peri-operative physician, anesthetists, but then our expertise as a physician will not be as good as any specialist cardiologist or chest physician or something, and there is always we should give advantage of this to the patient. So always the cross reference should be there. And it does provide us one additional layer of protection, because if something goes wrong and if you can show that you have taken care of referring him to particular specialist, taking his advice, following his advice, and in spite of that, the complication has occurred. So I personally feel that there is no harm in taking advice of other specialists. then proper informed consent, because we are not dealing here. Consent itself will need a special session. But in nutshell, the risk has to be explained. And at the end, always ask, do you have any other questions? So all questions of the patient should be answered. And then it has to be signed by patient, his relatives. It is better that as a witness, we ask the person who is coming with the patient to sign as a witness. Although witness legally can be anybody who is present there, can be signed as a witness. But I am very particular that the person who comes with the patient should sign it, for the simple reason that if something happens to the patient, it is that person who is accompanying the patient will create problem. So if he has signed it here, he will think twice before creating problem, and at least he cannot contest the consent, that proper consent was not taken because he has himself signed. Then we should be very careful when we take some impression of people who are illiterate and who cannot sign, because their name should be written in capital letters, and which thumb, it is left thumb or right thumb, index finger, whatever, it should be written, because all our different fingers have different impressions. It is not same. And all thumb impression look alike. So unless you write a name in capital letters that this is the left thumb or right thumb impression of this person, after a few years when the case comes, probably we cannot find out who has given the finger impression. And same thing about when the relatives or friends are signing, their names and their relationship should be written, whether it is a father, mother, friend, grandfather, whatever it is. So that should be done. Now I am coming to record, intercooperative record. I think there are many people who have different ideas. Some people record 5 minutes, some people record every 10 minutes, some people record even 15 minutes. But it is advisable that we record every 5 minutes the patient's parameters during operation. And that is our ISA guideline also says the same, and WFSA guidelines also say the same. Now, one thing I want to point out is that in Hyderabad, in one hospital, ERCP was done under sedation. A propofol was given and that patient died. And when they saw the record, it was recorded at a 20 minutes interval. And the judge made an observation that I presume that these 20 minutes anesthetist was not with the patient, because there is no record in these 20 minutes. And during that, the cardiac arrest happened. So he had to pay compensation. So when you record every 5 minutes, it gives an impression that you are continuously with the patient and you are recording every 5 minutes. So that is advisable. Then during recovery also, we have record all the parameters we have to record. Post-operative instructions should be very clearly written. That is also part of record. And discharge instructions also. So all these things form the part of our records, and nothing should be neglected. Now, this communicating bad news is a very important thing when something goes wrong with the patient, and is the most difficult task to do. But we should take some precautions. Number one is we should not disclose a bad news in a public waiting area or something. We should call the responsible people to a private room, and there we should talk to them. And that also only one or two people. We should not go to a very big group of people, because when this type of things happen, so many people come to the hospital. So it is not advisable. So it is better to take one or two responsible persons to a private place and talk to them. And then we should talk in a group, not anesthetists or surgeon should not talk alone. So we should talk in a group, surgeon, anesthetist, somebody from administration of the hospital, like minimum 3 people. And then we try to make them understand. And it is easier to make them understand if we have talked to them during PSC. If we have discussed their problems, possibilities, what complication take place, then it is easy to convince them in the post-op period. But otherwise it will become very difficult. And then don't suddenly, like a Bomb explosion, don't suddenly disclose the bad news. We have to bits. We have to say now. Say we all know that how it is done. That now he has gone bad. We are doing everything. Then BP is rising, falling like that. So in bits and pieces, we have to disclose it. Then we have to give adequate time because as long as the relatives are not convinced, we can't leave them. So we have to cancel all our entire schedule of the day after that case and give enough time to these people and satisfy them with our answers. And after once this briefing has been done, then the anesthetist and surgeon involved should leave the place. Otherwise, violence and other things will happen. They should leave the place and don't come for 2-3 days till the things become quiet. It is better to send them and let them relax than after 2-3 days they come, because people will be very violent and they'll say, where is the anesthetist, where is the surgeon, you want to see them and all that. So once this briefing of the relatives has been done, then let them go, and if there is any question, let the administration of the hospital answer those things. Otherwise, say you come after 5 days, then the anesthetist will come, like that. So by then the things will cool little bit. Now don'ts. So one thing is, don't give false insurance that nothing will happen. This happens many times. In I also, some surgeons say, oh, it will be, everything will be very fine. But always everything cannot be fine. And in anesthesia, of course, every time some complication happens, so there is no need to give false assurance. On the contrary, we should give a little more of the risk. Whatever risk you feel, you tell them little more than that. Because when you promise less and deliver more, it is better rather than promising more and delivering less. That causes problems. Then do not leave the patient unattended. So I pointed out that every 5 minutes parameters you write, and that gives an impression that you are with the patient all the time. Then do not administer GA for more than one patient. And this is happening in many institutions because they leave it to the OT technician and go to second theater, third theater, and only they tell that when something wrong happens, then please inform me, then I will come. So this is not acceptable at all. And if from the hospital and theater records, it can be proved that one anesthetist was handling 2-3 cases at a time, then defending is very, very difficult. So make a rule that one GA case, one anesthetist. There may be one GA case and two anesthetists in difficult cases, but two GA cases and one anesthetist is not acceptable at all. Then don't leave the record incomplete. You will complete the record, then only leave. Sometimes we think we'll write later on. And nowadays, I don't know how the records are kept. If they are not properly kept, anybody can take a photo with the a camera on the phone, and then if there is found that we have added something in the record, it will be very difficult. So before leaving, complete all the records and don't alter the records, because once you alter the record, they don't believe on your record, so entire your record becomes useless. So this everything that I have told you in these 15-20 minutes, I can sum up in CPD. We had all in obstetrics, we have all learned what is CPD, cephalopelvic disproportion. When in anesthesia now we forget about it. But now you remember it as communication, protocols, and documentation. So communication with the patient, very important, before surgery and after surgery. With patient and with relatives also. Protocols are very important because if you have protocols and you follow the protocols, then nobody can blame you for being negligent, whatever may be the result or outcome, whatever. But if you can show that you have followed the protocols, then nobody can point a finger at you. So many institutions don't have protocols. Protocols you can have, international protocols are there, national protocols are there. But if you don't have for a particular situation, you can have an institutional protocol, or you can even have a departmental protocol. But have some protocol. And if it does not work for say 6 months, you can change the protocol. To show something, you should have a protocol, and everybody should follow that protocol uniformly. That's important. Then documentation. So all that we have discussed should be documented in writing. So that's what I have to say. Thank you very much.
Thank you very much, sir, for a very informative presentation. I'm sure each one of us has benefited from it. I would like to ask our chairperson, Dr. Vavikar sir, to give any inputs if he has to, from surgeon's perspective.
Yeah. Yeah. Good evening, sir. Excellent presentation. The most important takeaway message is optimize. There is no emergency in ophthalmology which requires urgent care. Even
Yes.
if the patient has a ruptured globe, we can wait for a few hours, okay, with due precautions. So the most important point is optimize.
Yeah.
Regarding the consent, I would like to say that it is very important that we write down whatever the specific risk factor is concerned in handwritten form on the consent form and take the patient's consent there. If required, we can take a special consent also. Regarding medications, it is very important to make the patient understand which medications he should stop before surgery. Especially most of the patients are on blood thinners, and that can become a problem during surgery. In case of unexpected death, it is very important that you call your colleagues from nearby place, because many times the surgeon and the anesthetist, in whose hands this mishap has happened, they are not able to articulate things properly, and they may say few words here or there, which can create a problem. And we have had these situations in Thane where at a time, lot of doctors, colleagues came and they explained the situation, and the situation could be resolved. So I would like anesthesia. Okay, one more point, that many times we get a fitness in which it is written that patient can be taken for surgery with due risk. This due risk word is little dubious, and therefore whenever such words are written, it is very important for the patient to show that word with due risk and make them understand that the person who has given fitness also thinks of risk, and these are the risks which are involved, which have been explained to the patient. I think that's all. Documentation, sir, has covered very well, and if required, even police can be informed, or called to the hospital if we feel that there are too many relatives and the situation can go out of control soon.
Thank
I
you.
would like to add something
Yes.
that generally the patient is told not to eat anything after
Yeah.
midnight. That is not the instruction.
Yes.
So the patient does not take his BP medicine also, because then you ask him, he says, no, I was told not to take anything. So we must be very careful about it. We should tell that these medication you have to take. And the patient comes and we find the blood pressure is very high and all those things. Second thing is there's no harm in giving a tablet of Restil of 0.5 milligram to every patient, irrespective of blood pressure or anything, because everybody will have some anxiety and will not get good sleep when next day there is operation. So I think every patient who is undergoing surgery, give him 0.5 milligram of Restil, so that he's calm and quiet when he comes and these problems are not there and unnecessary cancellation and postponements are not there. Thank you.
So there are a couple of questions in the chat box, like about the NBM you have already said, and whether to discontinue blood thinners. Would you like to tell anything about it, sir?
Yeah, blood thinners, we do. See, depends upon surgery. See, for
Depends
cataract
also.
surgery, even if you don't stop, it doesn't matter because there is not much bleeding involved. But then when you go to oculoplasty and all these things where so much bleeding is there, then we have to be very careful about, and we have to follow the protocol of stopping uh, this blood thinners. And after stopping, we must do the test also, okay, whether this stopping as how much coagulation profile has been affected on all the thing, and then do it.
Yeah, sir, again, there is a question in the chat box. Like earlier, the Dr. RNR, good evening. Earlier, the fasting guidelines were 246 and now it is 136.
Yeah.
So would you like to, sir, enlighten us about it?
Yeah, doctor, actually, the latest guidelines say that 246 is not updated to 136.
Okay.
So we are, we means I cannot say all my colleagues, but I am following this latest guidelines, and we are also doing some studies on that, like after taking a plain water with the ultrasound after 1 hour, whether we just check whether the water is still there in the stomach or any, if it is milk, up to what level we are doing a study, and I have requested some of our other colleagues in Mumbai, Shantilal Sanghvi High Hospital, Dr. Sujata, she was a pediatric anesthetist over there, to do the same study over there. But the latest guidelines say that it is 136, and many of them are following it.
Okay, sir. Thank you so much, sir.
I think it's better to err on the safe side. So there's no harm in whatever way you are comfortable, but it's better we don't take any chances till the things are totally proved. Then, and if ultrasound is there is no problem. You can immediately assess before shifting the patient to how much is the gastric content there.
Sir,
About
actually,
the blood
problem.
about the blood thinners, what you were talking now, again, ecosporin maybe need not be stopped, but especially patients who are having stunts and all, according to the literature, I think you should not stop the blood thinners. You can continue them.
Okay.
I don't know. That depends on individual, as Dr. Parekh has rightly said, that depends on individual surgeon and the anesthetist and the perioperative physician who takes care of the patient. But if the patient is having stunt or anything like that, I think blood thinners have to be continued.
Sir, I disagree with the thing. I am Dr. Renu.
Yes,
Dr. Renu, come on.
Yes, sir. Yes. So once you are talking about the fasting, I think saying 1 hour is very good, but we don't know at what time the next patient will be done, because many times you think that the previous surgery will take 1 hour, but it is finishing less than 1 hour. So 1 hour and 2 hour are mainly concerned about those preterm babies, in which otherwise a 4-year-old child, whether it is taking water at 1 hour before the surgery or 2 hour before the surgery, there is no much difference of that. Because anyway, normally also you are not taking 1 hour. After 1 hour, you are taking some water to drink. So having 2 hours is also okay. So it should depend if the child is obese.
Dr. Renu, actually, these guidelines, so you see, suppose the patient comes there and the anesthetist or whoever, the pediatrician or the physician, they should not make them wait. Suppose the patient has taken plain water 2 hours, 1 hour before, and they should not make them wait for 2 hours. That is the thing what we are telling.
Plain water 1 hour is okay, but not for the milk, because if you say for the milk, then breast milk, then the child's age is also important. So
yeah, that's what was before 4 hours has become 3 hours, and what was before 2 hours has become 1 hour. That was the thing I wanted to mention.
And regarding the blood thinner, we cannot say that the patient should continue or patient should discontinue, because it also depends upon the type of surgery. If you are doing a oculoplasty surgery and you are continuing the blood thinner, there will be increase in bleeding. If you are doing a glaucoma surgery, in the glaucoma surgery itself, it is written that there can be vision threatening.
Yeah, that's the reason I told that depends on the surgeon and the anesthetist to decide on before the surgery.
It depends upon this type of surgery much more than other things. Because for VR, and if the stent is more than 1 year, then cardiologist has no problem in stopping it if the patient is taking anticoagulant because of AF and there is no thrombus. Surgeon has no problem, cardiologist has no problem stopping warfarin for 5 days. So again, I say that patient consent should also be taken if there is 1% increase in the risk of hemorrhage, whether that patient is going to take, because many times cardiologists said that there is no problem in stopping the drug 5 days before the surgery for 5 to 6 days. And at that time, if something will happen, the patient will say that why I should take the risk of hemorrhage if it is more than 1% or 2%.
That's the reason I added that depends on the surgeon and anesthetist, Dr.
Surgeon, anesthetist, and patient and cardiologist, and the type of surgery.
Type
All
of
things.
surgery is okay, but
No,
what is
patient should
what
also
is the role of the patient over there? Patient to patient attenders.
It's patient's eye. If you are saying that if you are continuing the anticoagulant, there will be chance of having hemorrhage is 4%, but if you are not continuing the anticoagulant, then it is 0%. Then it is the patient's eye who is taking. So my patient said that I want to talk to my cardiologist, and if the cardiologist is saying there is no harm in stopping for those 5 days, I want to stop that, and I will come later on. So you have to tell your patient that this much % of chance is increased. Once you are seeing meta-analysis, you are saying only 1% patients has increased bleeding. So those 1%, who are those 1%? Nobody knows. So your patient will say, if there is any problem, then he will say that I was not informed that there may be increased risk of hemorrhage during the surgery. There may be increased risk of hemorrhage during the peribulbar block if you continue the blood thinner. I was not consulted regarding that 1% increase of hemorrhage. We had 2-3 patients who said that we will not go ahead with the surgery because this is an elective surgery and we want to go to our cardiologist to discuss it much more than what you are saying, and then we will come back.
Oh, this suggestion by cardiologist is a must, or the physician can also. Do you think the cardiologist, apart from
in my place, if the cardiac problem is there, then cardiologist is the best person. So if your patient want to go to his cardiologist, let them go.
Yes, ma'am.
I would like to add one point.
Yeah.
It is very important, very good discussion. I would like to add one point, is that it is very important for the everybody, patient, staff, and doctor, anesthetist, as operating surgeon, to inform the patient repeatedly to start the blood thinner as early as possible.
Yeah.
Yes.
Sir, many times it has been seen that in the OPD, the ophthalmologist stop all the drugs. Even aspirin, clopidogrel, and all other things. It is so difficult to teach the ophthalmologist also that you are not the person who should decide about that. Even in some patients who had aortic valve replacement, we see that warfarin is also stopped for cataract surgery, which is done under topical. So it is ongoing process to teach everyone.
Yes, ma'am. Thank you so much for all your inputs. Thank you, sir, for a wonderful.
One more point I want to tell you very small, like this about post of fasting.
Okay.
Because I usually, for a child who is 4 years or above, who can ask for, express that I am hungry, I don't write time. I always write till the patient demands. Because if patient can demand, it is safe, he will not aspirate. But otherwise, if I write time, then because the parents are waiting that which child has been fasting overnight. So immediately as soon as that period is over, they will try to feed irrespective of the condition of the patient. So I usually I always write that till the patient demands, don't feed him.
Sir, we give them feed as soon as they are awake and they are crying. If the smaller kid, if they are crying, we tell them.
Small children will cry. Those who can ask for food, big 5
we
years and above.
we ask.
So when he demands, give it.
Sir, we ask them whether you want to take water or not, and most of the time they say yes, we want to take, because they are actually awake.
Yes. Thank you so much, everyone, for a great discussion. Thank you, sir, one more time. Moving on to the second topic, that is blocks in ophthalmology. Nowadays, blocks in ophthalmology are mainly given by anesthesiologists. Our next speaker for today is a senior anesthesiologist who is going to share her experiences on this topic, Dr. Aruna Gaitonde, madam. Madam was earlier attached to Singhania Hospital and Kaushalya Medical Foundation. Now she is practicing ophthalmic anesthesia exclusively at Bhaskar Eye Care Hospitals, where she is also a director and co-founder. Welcome, madam. I request you to start your presentation.
Good evening, everyone. At the outset, I would like to thank Hani ISA for giving me this opportunity to talk on this platform. So, just like Dr. Parak said, no GA if LA can be given. So, today I'm going to talk about regional anesthesia in ophthalmology. So, most of the cases, eye surgeries are done under regional anesthesia. Yet, there are some cases where we need to give general anesthesia, like in pediatric cases or mentally challenged patients or uncooperative patients or open globe injuries or some adult strabismus cases also. So, centuries back, eye surgeries were done without any anesthesia. And over the years, ophthalmic anesthesia has evolved tremendously. The year 1884 was a watershed year of ophthalmic anesthesia. At Kohler had discovered cocaine hydrochloride, and he had used it as drops for topical anesthesia. In the same year, Knapp used it to give retrobulbar anesthesia. The 90s saw the advent of peribulbar blocks and subtenence block. Today, most of the cataract surgeries are performed under topical anesthesia, and some adventurous surgeons do claim to do cataract surgeries without any anesthesia. So, before we embark on to the actual blocks, one should know functional anatomy of the eye. This here is the picture of orbit in which you can see the medial walls.
Sorry, your slides are
of the
not
orbit.
visible.
Madam, you are still in the
Excuse me,
first
ma'am.
slide.
Slides are not visible.
We can see only the first slide, madam. You'll have to go to the next slides.
It's not visible?
The first slide is seen, ma'am.
I'll start again. Shall I? Now can you see?
Now we can see the
No?
Zoom. Yes. No, we cannot see your presentation. We are
Can you?
back to the Zoom. You can try sharing one more time, madam.
Mithila, can you see this? Okay, huh? Mithila.
Madam.
Mithila. Share होत नहीं है
Madam, I will share it for you if you want.
हाँ, 1 minute, huh? I'll just try sharing it.
Reshare करा.
No, 1 second.
Now is it visible?
Now is it visible?
Yes, madam. Yes.
Yeah, you can just make
Yes,
it
no?
screen.
Visible, madam,
screen,
visible.
Visible. It is seen. You can make
Just
it.
make it full screen.
Yes. The first slide now. Yeah. And
Yeah. Now this is the function. Can you see?
Yes, madam. We can see the slide of anatomy of eye.
Yeah. Yeah, functional anatomy of the eye. Here you can see the medial walls of the orbit are parallel to each other. The lateral walls are at a right angle to each other, and the globe is suspended anterosuperiorly in the orbit. If you look at the eye from the side, you can see the recti muscle. They form a cone and they divide the orbit into intraocular space, intraconal space, and the extraconal space. If you look at the front of the eye and you drop two planes, one vertical and one transverse, the orbit is divided into 4 quadrants: the superonasal, the inferonasal, the superotemporal, and the inferotemporal. The nerve supply of the eye, the afferent supplies through the ophthalmic division of the trigeminal nerve. The inferior part of the orbit, it is supplied by a branch of the maxillary nerve. The efferent supplies through the cranial nerves 3, 4, and 6, and the orbicularis muscle, it is supplied by a branch of the facial nerve. The parasympathetic supplies through short ciliary nerves. The sympathetic is through the long ciliary nerves. So now, equipped with this knowledge, let's see what are the types of blocks. The types of blocks are akinetic blocks. Just as the name suggests, it produces akinesia or absent eyeball movements along with analgesia. So these include needle-based blocks like the retrobulbar and peribulbar, and cannula-based block, that is the subtenence block. Then there is the non-akinetic block, which is topical blocks and blocks for oculoplasty, surgeries. So let's start about the retrobulbar block. Just as the name suggests, retrobulbar blocks historically have been the gold standard for hundreds of years. Even when I started my practice, I must have given almost thousands of retrobulbar blocks. And but I always used to be apprehensive because my needle was going blindly behind the eye. Or globe or the optic nerve itself, But I have been very lucky, and that's by the God's grace. And this is the site of the injection where you introduce in the eye. So previously to be given the medial 2/3 and lateral 1/3, but vascular area now you as temporally as possible in the infratemporal compartment. And you use a 24 gauge needle, and it is inserted through the point which I told you, and to the below of the eye. And after it has reached the equator of the eye, the needle and also it is so close to the optic nerve. So once the needle has reached in this space, 2 to 4 ml of the local anesthetic is injected over here. Now what happens over here is, because the orbicularis muscle is supplied by the division of the facial nerve, it does not get blocked. And so we need to give an additional facial block along with retrobulbar injection. So what is the peribulbar block? It is in peribulbar space and the section are retrobulbar. This is the lateral peribulbar block. And if that is not adequate, we need a medial peribulbar block. I'll talk to you about it. So here a 25 gauge needle is introduced into the extracorneal space to a depth of 25 millimeters or till the hub reaches the plane of the iris. And a volume of about 6 to 8 ml is injected in this space. Now, the extracorneal and the intracorneal space communicate with each other freely because there are no septum or fascia both the spaces, and hence this volume spreads to the intracorneal space and produces an excellent block. That is, there is excellent analgesia as well as akinesia. Also, this local anesthetic diffuses through the orbital septum and comes to the orbicularis muscle too, and there is no need to give a facial block. But such a large volume can also exert pressure on the eye. So we need to give digital pressure on the closed eyelid for 30 seconds. After every 30 seconds, the digits are lifted for 5 seconds so that ocular pulsations can occur. And we do this for 2 to 3 of the block. If there is residual eyeball movement, then we need to give the medial peribulbar block, which is given with 26 gauge half-inch needle, and it goes in between the medial canthus and the caruncle. And about 2 to 4 ml of local anesthetic is injected over here. This gives, now the block is complete, all the muscles are paralyzed and the eye is ready for surgery. Let's talk about the subtenos block. This is a cannula based block, and here the local anesthetic is placed in the space between the sclera and the Tenon's capsule. Now this what is the Tenon's capsule? It is nothing but a fibroelastic layer which stretches from the limbus anteriorly and it goes to the optic nerve posteriorly. This is a potential space and it expands when a fluid is injected into it. So I will demonstrate. I'll show a small video to show you how the subtenon's block is given. This is courtesy Dr. Saurabh Patwardhan from the Nandadeep Eye Hospital. So in this video, you can see that the block, the site of the block, the infranasal quadrant is the preferred quadrant to give this block as you avoid injury to the muscle and the vessels. And this block is injected about 5 to 6 millimeters away from the limbus. The reason is that 2 to 3 millimeters from the limbus, the Tenon's capsule is fixed to the limbus. Hence, now here you see the surgeon is infiltrating the conjunctiva with a local anesthetic. And you can even do this with just paracaine drops or lignocaine drops to anesthetize the part of conjunctiva where you want to give a nick. And the conjunctiva along with the Tenon's capsule, it is picked with a forceps and a small nick is made to explore the sclera. Now, a blunt curved cannula, which is mounted on a syringe with local anesthetic, is introduced through this cannula and it goes posteriorly towards the equator. And about 2 to 4 ml of the local anesthetic is injected over here. It produces excellent anesthesia as well as akinesia. It takes about 2 minutes for the analgesia to set in and about 6 to 8 minutes for the akinesia to set in. So it is the inferonasal quadrant is the preferred quadrant, and the injection is made, the nick is made at 5 to 6 millimeter from the limbus with a blunt Westcott scissor, and a blunt cannula is inserted over here, and 2 to 5 ml is introduced into the subtenon's space. So injection of the local anesthetic in this space, that is the subtenon space, blocks the sensation from the eye by action on the short ciliary nerves as they pass through the Tenon's capsule to the globe. Akinesia is obtained by direct blockade of the anterior motor fibers as they enter the extraocular muscles. Now, this block is preferred when where the needle block may prove risky, like in deep set eyes or high myopes or uncontrolled eye movements, or it is very useful as a supplementation block for topical or peribulbar. Many times during the surgery, the patient still after giving a peribulbar block or a topical block, patient still complains that I'm having some discomfort, I'm having some pain. And so you can supplement this with the subtenon's block very, very easily intraoperatively also. This block, many times the retinal surgeons use it for peripheral retinal lasers, cryo, or for cyclophotocoagulation in glaucoma cases. But one has to be wary about this block because there are certain limitations to this block. So when there is subtenon scarring, it is difficult to give the block because it is difficult to approach the subtenon space. So generally subtenon scarring you see following chemical burns, or when multiple times the retinal surgery has taken place, or the strabismus surgery has taken place. So during this scarring, it becomes difficult to give the block, and it is preferable to give it, use some other method for blocking the eye. There are other limitation is thin skin after chronic scleritis. In the past, a patient has osteogenesis imperfecta where they have thin blue sclera. Some cases of large pterygium, or patient who have suffered severe conjunctivitis, chronic conjunctivitis in the past, they have fleshy conjunctiva. And in such cases, it is difficult to approach the subtenon space. Also, it can cause quite an amount of bleeding if it is attempted in patients with fleshy conjunctiva. Now, let's see what are the complications of the needle. Complications or systemic complication. The orbital complications, let's deal with them one by one. Retrobulbar hemorrhage. This happens usually when a vein or a artery is punctured while giving the block. So it usually happens in retrobulbar blocks, because the needle is going back in the retrobulbar space where the vascular structures are prominent. And if there is an arterial puncture, then it causes a hematoma very fast and it produces compression of the eyeball. And it is seen as a proptost eye, and the lid gets swollen immediately, and there is ecchymosis, and the IOP may rise tremendously. So it is wise to postpone the surgery when there is an arterial bleed. The venous bleed, on the other hand, forms the hematoma very slowly, and it is seen as a chemosis in the front of the eye, and this compression limits this venous bleed, and there is no need to postpone the surgery, and it can be carried out as planned. A long needle used in retrobulbar block or retrobulbar block in an eye which is in a big in a myopic eye can cause injury to the optic nerves. The optic nerve fibers get damaged and it can cause loss of vision. Extraocular muscle injury and myotoxicity can occur if the needle goes through the extraocular muscles, or the local anesthetic is injected in the muscle, and this can cause diplopia. And if it is injected through in the upper medial peribulbar block, it can even cause ptosis. But this is a self-limiting, because the diplopia and the ptosis, they get corrected in 2 to 3 weeks time. Now, systemic complications are allergic reactions of local anesthetic, but more side-threatening or life-threatening are the CNS complications. The CNS complication can be through intraarterial injection or injection through the optic nerve sheath. So inadvertent or unintentional intraarterial injection may result in the retrograde flow of the local anesthetic from the ophthalmic artery into the anterior cerebral or the internal carotid artery, resulting in the CNS spread of anesthesia, a CNS spread of anesthesia. So a volume as small as 4 ml can cause convulsion in the patients. Now this can be treated by maintaining a patent airway, oxygenation, and giving anticonvulsants to the patient like benzodiazepine or propofol or thiopentone. The second mechanism is an unintentional subarachnoid injection can occur via the puncture of dura mater sheath of the optic nerve. This can result in partial or total brainstem anesthesia depending upon the dose and the volume of the local anesthetic spreading to the brainstem. The signs and symptoms that are seen are violent shivering, contralateral amaurosis, loss of consciousness and paresis, which can be hemi, para, or tetraparesis. The involvement of the cranial nerves 8 to 12 can result in deafness, tinnitus, vertigo, dysarthria, dysphagia, and aphasia. It can even produce total spinal anesthesia leading to cardiorespiratory arrest, and early detection of this complication can be life-saving, or delay in diagnosing and treating may prove fatal. So treatment is on the lines ki you may need to intubate and give mechanical ventilation, adequate oxygenation, and use of vasopressors. Now let's see what topical anesthesia is about. So the advent of clear cornea phacoemulsification combined with foldable lens implantation has popularized topical anesthesia technique as a safe and easy form of ocular anesthesia. So this is achieved by instillation of 0.5% proparacaine drops about 5 to 10 minutes every half an hour before the surgery. And you can even use 2% lignocaine jelly for the same. Now what happens is this blocks the trigeminal nerve endings in the cornea and conjunctiva, But this leaves the intraocular structures in the anterior segment unanesthetized. So the manipulation of iris and stretching of the ciliary and zonular tissues can irritate the patient, and it can cause pain also to the patient. Hence, intracameral 0.5 ml of 1% preservative-free lignocaine is instilled through the side pore. Now, this produces good intracameral anesthesia, and there is sensory blockade of the iris and the ciliary body, and the surgeon can comfortably complete the phacoemulsification and the implantation. Now, there is one disadvantage with topical anesthesia, that is as the optic nerve is not blocked, the patient can see the light or colors and the movement which the surgeon is making, the hand movement and the instruments, the patient is able to see, and sometimes this is an unpleasant experience for the patient. But good preoperative counseling helps to alleviate, and like Dr. Parak said, it helps to give rest till pre-op, so the patient becomes comfortable in the operation time. So oculoplasty blocks, these are given for surgeries on the upper eyelid, the lower eyelid surgeries. The various blocks, those are written over here, like supraorbital blockage of supraorbital nerve, infraorbital nerve, anterior ethmoidal nerve. This is the tract that is blocked when you want to do lacrimal apparatus surgery, and a facial block. So about 2 to 3 ml of the local anesthetic is infiltrated through these sites to give the surgery, depending upon whether it is upper eyelid or lower eyelid. And generally, the oculoplastic surgeon prefers to use xylocaine with adrenaline, because these surgeries are quite vascular. So it helps them to maintain a good feel while they are giving these blocks. This on the facial block. There are two techniques. This is the O'Brien and this is the Van Lint. In O'Brien, you select the point of insertion is one finger away from the tragus and one finger below the tragus. The local anesthetic is injected over here after feeling the head of the mandible, and it is injected at the neck of the mandible after the needle goes inside and touches the neck of the mandible. The needle is withdrawn a little bit, and after negative aspiration, the local anesthetic is injected. Other method where you can block the facial nerve is in the Van Lint method. This is about 2 centimeters away from 1 centimeter away from the lateral orbital wall. The needle is introduced over here, and it moves superiorly and then inferiorly to infiltrate this area, which again blocks the facial nerve supplying the eye. Now, what are the drugs that are used in these blocks? The local anesthetic that are used are 2% xylocaine without or with adrenaline, 0.5% bupivacaine, and recently newly added is 0.75% ropivacaine. And the adjuvants that are commonly used are hyaluronidase. Some use even clonidine and dexmedetomidine, epinephrine. But what I do is I take 1 vial of hyaluronidase, that is 1,500 international unit. I mix it with 30 ml of 2% lignocaine, and I take 6 ml of this mixture, 4 ml of bupivacaine, and in a 10 cc syringe, and this I use to give the peribulbar block. And ropivacaine, of course, has an advantage. It is less cardiotoxic and the block remains active for a longer time. But I have not used it as yet. So the role of hyaluronidase is it's an enzyme that reversibly liquefies the interstitial barrier between the cells by depolymerization of the hyaluronic acid, and thereby it enhances the diffusion of the reagent through the tissue planes. So it acts wonderfully when you have added hyalase to it, I, for myself, have never used clonidine and dexmedetomidine with the blocks, but these are supposed to provide post-operative analgesic and prolongation of the block. A word on the role of phenocaine. Now, phenocaine is a injection which is a combination of 1% lignocaine, 0.2% phenylephrine, and 0.1% of tropicamide. So many times during the topical anesthesia surgery, the patient still complains of pain in spite of intracameral injection. And many times touching of the iris also causes miosis. So when you infiltrate phenocaine, then it causes mydriasis as well as it alleviates the pain. So we use it many times in our setups. Before I end, a few words on oculocardiac reflex. So this is the decrease in the heart rate by 20% of the baseline value, and it is most commonly seen during strabismus surgery because there is attraction on the extraocular muscles. And the other triggers are if there have been a retrobulbar hematoma, or in glaucoma cases, or when there has been an ocular trauma, stretching of the eyelids or conjunctiva. Actually, it can be even seen when you're giving during the blocks. What happens is before the action of the block comes, the block itself, the injection itself can induce oculocardiac reflex and produce bradycardia in the patient. So this is the arc. I am sure all of you know this. The sensations are carried to the main sensory nucleus of trigeminal, and the efferent comes through the motor nucleus of vagus to the cardiac depressor to the SA node, and it produces bradycardia. It can even produce asystole. So on a lighter note, this is what happens to the patient, and this can happen to the anesthesiologist. So thank you very much.
Thank you so much, madam, for sharing your experiences in various blocks in ophthalmology. If Dr. Jayachandran sir is around, we would like to, whether he would like to add anything, sir. Good evening, sir.
Good evening. How are you?
Hello, sir. Yes, sir. Yes, sir. You are audible. Good evening, sir. Would you like to add?
Tell me. Yeah, actually, someone has asked about the hyaluronidase toxicity. Am I right?
Sir.
One question in the chat.
Yes, sir. Yes, sir.
So, actually, 2 points are there. One is that the dose should be limited. Very important. It should not exceed more than 17 or 20 international units per ml. Okay, that is very important because many of the ophthalmologists, they just like that mix 1,500 units in xylocaine and just like that they give. Okay. And the other point is, if there is any history of any allergic reactions to animal protein, then better to do a skin test dose and then we perform the hyaluronidase injection, because most of the times we do come across allergic hypersensitivity reaction following second time eye surgery, though the first time eye surgery will be uneven. So in those cases, it is always better to do a skin test, allergic skin test, and then perform it. So these are the few points which I would like to add upon. Thank you.
Thank you, sir. If there are no further questions, we can move on to the next topic.
Can I add a few points?
Yeah, sure, sir.
First thing is that while giving every block, it is very important to aspirate. Just to
Yes. Definitely, yes. After negative aspiration, you have to inject the local anesthetics. Yes.
Absolutely. And whenever there is a undue resistance while injecting, it is better to stop and redo the entire procedure. Yeah. Second point is that xylocaine drops or paracaine drops we are putting for topical. We should always put only one drop at a time. We have a mental satisfaction of putting 4 or 5 drops, but it causes corneal toxicity and epithelium becomes hazy and surgery becomes
epithelial toxicity.
Yeah, epithelial toxicity. And the third point is when to give xylocaine with adrenaline and without adrenaline. That also needs to be looked into. There are some patients who are high risk for giving block with adrenaline, and inadvertently, suppose the block goes in a vessel, it can be a problematic. So please read the fitness carefully. If it is mentioned without adrenaline, then we have to do so.
Thank you.
Actually speaking, for orbital blocks, there is no need to give the adrenaline mixed lignocaine. It can be used mainly for skin infiltration, oculoplasty cases. Whereas
Yeah,
for
that's
giving
what
the
I
orbital,
said. That's what I said.
yeah,
We use it generally for oculoplasty cases. For
for orbital
inside the
blocks,
globe, we use
avoid adrenaline mixed lignocaine.
yes, yes. We use plain xylocaine, yes.
Squint surgeons use that, madam, with adrenaline.
Just one thing I wanted to say, you talked about the phenylephrine drops.
Yes,
I
sir.
think we have to be very careful while putting the phenylephrine drops, because we have seen many patients. What happens is, to impress this ophthalmologist, the PGs, the fellows, or the pre-operative area nurses and all, they go on putting the phenylephrine drops, and the patient lands up in hypertensive crisis, because one of the slides the doctor was mentioning about the phenylephrine drops along with some other sedatives. So what we do is, we don't make the people plus drops with them. We keep it in the store, and it has to be taken really if it is necessary for them to put the drops.
Thank you, sir.
Can I ask a question, please?
Sure, sir.
Yeah.
Hello.
Yeah, tell.
Hello.
We can hear you.
Yeah.
Okay. Do you have any problem by giving the perivertebral block in obese patient?
Obese patient?
Yeah.
Yeah. So what happens is, whenever I'm giving these peribulbar blocks, I want the gaze to be in the primary gaze. Okay. So if the patient is obese and has thick neck, I have to adjust the position of the head and neck so that I get the primary gaze. So important is that I achieve the primary gaze by adjusting the head and neck position, either putting a roller this under the blades of this, and once the primary gaze is achieved, I don't face any problem.
Do you get the complete akinesia in this patient with primary block?
With obese patients?
In obese patient, when the eyes are bulky and you give the one block and patient doesn't get the complete akinesia.
No, with one block, I may not get, so I usually give the second block along with it. Yes.
Yeah, that's the question. Because many a time in obese patient, the 5 ml of the xylocaine or betagrel you give, the local anesthetic agent does not provide complete akinesia in this patient. That's my worry.
Madam, you mentioned about ropivacaine, but I'm not sure if ropivacaine can cause, complete akinesia. So
Ropivacaine doesn't cause akinesia.
yes. So I think for blocks, I think it should not be given.
No, 0.75% ropivacaine can be used. 0.75.
Sorry?
Don't use 0.5. 0.75%
75%.
ropivacaine. Yeah.
0.7.
Don't use that 0.5. You can Google it and see there is an interesting article published by me comparing 0.75% ropivacaine and 0.5% ropivacaine and 0.5% ropivacaine for VR surgery.
Thus, the duration has found
elevated to 0.75% ropivacaine. So it can be used.
Okay, sir.
Thank you.
Thank you, everyone. We can move to the next topic. That is TIVA in ophthalmology. TIVA has become more popular, practical, and possible solution in anesthesia. And we have another esteemed speaker, Dr. Manjula V. Ram Salim, Madam, to present on this topic. Madam is a professor, Department of Anesthesiology, Gayatri Vidya Parishad, Institute of Healthcare and Medical Technology, Visakhapatnam. She has nearly 22 publications in national and international journals. She has received Best Paper Award in National Journal of IJOA. She has presented papers in national and international conference. Let's hear from Madam about safe practice of TIVA in ophthalmic anesthesia.
Good evening, all. Greetings from Visakhapatnam, Andhra Pradesh. Good evening, all my senior and junior colleagues. It's an immense pleasure to be with you all vibrant ladies around. And special thanks to Dr. Manisha and team of ISA Thane City Branch and SAMS. So I welcome you all to the Indian Association of Ophthalmic Anesthesiologists. Today I will discuss a little bit about TIVA in ophthalmic anesthesia, which we just presented in our national conference recently. So we will be discussing about what are the special indications for TIVA, definition, why I should use TIVA, and what are the different types, different methods, how I use TIVA, and what is special about PK and PD, and what are the different drugs used, and if I don't have a TCI pump, how do I use, and advantages and limitations, and especially I will consider a little bit in the last few slides about what are the ophthalmic considerations here. So there are here TIVA can be used for almost all the cases, but the special indications, few patient indications like surgical factors and procedural factors are where we need TIVA. So like patients with history of malignant hyperthermia or muscular dystrophy or previous history of emergence delirium, history of PONV or upper respiratory tract infections, we should consider TIVA. And surgical factors like where we knew the surgeries around the airway or shared airway, whenever there is a requirement of intraoperative neuromuscular monitoring. Like procedural factors include like when anesthesia is required in remote area, what we call as NORA or daycare surgeries, and some small procedures like muscle biopsy, we can consider TIVA. So history we can trace back up to 1900 with the introduction of IV barbiturates. Later in 1985, Stephen Schaeffer published the study and laid foundation on the TIVA systems. Only later Michael Glass developed the first TCI dip prefuser. That is, TCI means target control infusions using the PK model that was developed by Schaeffer. So what is TIVA? TIVA is a technique in which the general anesthesia is induced and maintained with IV anesthetic agents. And in recent times, it is possible because of the PK and PD properties of the propofol and the availability of the short-acting synthetic opioids. So how it is different from conventional anesthesia? So in conventional anesthesia, like tired of anesthesia, what we say is unconsciousness or amnesia, muscle relaxation, and analgesia. So we do induction mainly with either in IV and anesthetic agents, and in pediatric or in small kids, we use inhalational induction and then maintain with mainly the inhalational anesthetics. And analgesia and muscle relaxation remain the same. Either you use bolus doses or you use continuous infusion, but in TIVA, the induction and the maintenance both are with the intravenous anesthetic agents. So regarding the types of TIVA, we may require muscle with or muscle without muscle relaxation, with or without endotracheal tube. We can use TIVA. You can use it with supraglottic airways, or if you don't want to use supraglottic airways, you can just use it with the oral or the nasal airways. So what are the different drugs we use for TIVA? Mainly the main drug when we think about TIVA comes is propofol. So the hypnosis can be maintained either with propofol, ketamine for small procedures, benzodiazepines, and barbiturates. Analgesia remains the same either with fentanyl, remifentanil, alfentanil. So TIVA main drug used is remifentanil, and the use depends upon the availability of what drug you have. And the muscle relaxation, you can use rocuronium, vecuronium, or cisatracurium. Either you can use it in bolus or you can use infusions. So when we think about the ideal IV anesthetic agent, first drug which fits into the ideal drugs is propofol. So as it has no active metabolites, it has a very short context sensitive half time, that is 8 minutes. It is very rapid in onset. It has other properties like anti-emetic, anticonvulsant, and it is not a trigger agent for MH, that is malignant hyperthermia, and it is also a membrane stabilization. So it maintains the cerebral blood flow because it autoregulation and CO2 responsiveness are not affected. So how you are going to administer TIVA? So it can be, till now we are using intermittent bolus doses, like whenever small procedures are there, we use propofol in induction, and then we maintain with a few ml of whenever the patient moves or something. Or we can use constant infusions like manual syringe pumps we can use, that we will discuss in the next few slides. You can use target control infusions, which is latest in trend. We will see how it is useful, and we can use either through the closed loop anesthesia, that is CLAM. So intermittent bolus doses, when it is given in the bolus as an injection, it results in the increase in the peak blood concentration. But after a few minutes, it decreases in concentration, then the anesthetic effects will fluctuate widely. So it is only acceptable in short duration procedures, and that too in unparalyzed patients. So in manual infusions, it is used in the multi-step infusions regime, that is bolus, elimination, and transfer. So whenever we give a propofol initially, it gets distributed in the central compartment, that is plasma and the blood. So after that, it gets distributed to distributed to the V2 compartment, that is the vessel rich poor, that is the muscle compartment, and later on to the V3 compartment, which is very big in size, but it slowly gets distributed. After some time, you can see that there is an equilibrium happens between V1 and V2, V2 and V1 and V3, and at the same time some amount of elimination also happens. After some time, the concentration of the propofol also is reaches the effect site, that is the brain, depending upon the receptors available. So here you can see the V3 compartment is very big, that is the volume of distribution. It takes more time to get distributed. So that is from induction to maintenance, we need to give the volume that is required to get distributed and to reach the effect site. So we should know a little bit about the Ke0. It is the rate constant of equilibrium of the anesthetic drug between the plasma and the effect site. It indicates the speed at which the effect will be obtained, and every drug has got its own Ke0. The concept of Ke0 has helped us to develop the TCI models with the effect site targeting instead of plasma. Hence, the time for onset of the action after IV injection of a drug is not one brain arm circulation, but it is the Ke0. So the final effect of the IV drug depends upon the receptor theory. That is, either it can be agonist, antagonist, and partial agonist. How much the drug has reached the effect site, that is GABA for propofol and thiopentone, NMDA receptors when the ketamine is used, mu receptors when the opioid is used, and alpha receptors when the dexmedetomidine is used. Depending upon that, the effect will be there. So it also depends upon how many target receptors in the organ are occupied by the drug. So for any drug, the concentration effect may range from no effect to complete isoelectric effect, depending upon the BIS values. So now we will know a little bit about what is TCI. TCI is an infusion system whereby the target concentration of a particular agent that is selected is delivered. It has three compartments. That is computer, which interacts with the user. and infusion pump and the interface with the user. Depending upon the interaction, the computer selects the PK model and calculates the infusion rate. The infusion pump then delivers the drug at a particular rate as given by the computer. So this pump also has many other sensors, how much the drug is delivered, whether is there any air in line, any occlusion in the system. So when we talk about these TCI models, most of commonly the propofol is used. So I'll talk a little bit about the propofol and then we will go to the other drugs. So this propofol TCI allows easy control and rapid change of the target propofol concentration. Whenever these unpremedicated patients are to be induced, the target, we have to set the target propofol concentration of 4 to 8 micrograms per ml for induction. And if you are using other drugs, we can reduce the concentration. So for maintenance also, when we are using with any other analgesics or any additives, adjuncts, we can reduce the maintenance concentration, maintenance level. So the lower target concentration can be used depending upon the age of the patient and the requirement and the volume of distribution the concerned patient is requires. So it can also, same thing can also be used for children also. So for propofol, we have different pharmacokinetic model, different systems, that is Marsh, Snyder, and Eliveld. In Marsh, it calculates the plasma concentration. So the demographic that is used is weight only. So as shown in the compartment variable V1, that is the initial volume of that is central compartment, it calculates as a huge volume of compartment, that is 12.96 liters. So it requires a larger induction dose, which is fast. That's why it is faster, causes faster induction, and also requires a larger maintenance dose. So it is used mainly for the young and healthy adults. So Snyder, you can set either plasma or effect site concentration. So it uses height and weight. So for obese patients also we can use this because it calculates the lean body mass and then it gives the infusion rate. So here the central volume of distribution is 4.27. So for this induction is little slower and smaller doses will be required, and overall the less propofol will have a less propofol consumption. So here the patients will be mostly hemodynamically stable. So it can be used for elderly and frail patients. So Eliveld is the modified form of Marsh model. So it for this it is a universal model that is called, and it uses all the demographic characters, and it can be used for different drugs also, like remifentanil, sufentanil, and propofol. So here on the left side, you can see that the therapeutic range propofol is 1.5 to 5 micrograms per ml. That is the plasma concentration. So depending upon the depth of anesthesia we need, I'm talking here because depending upon the depth of anesthesia we require, we can set the plasma concentration or the target control infusion dosage we can set, and we can use it comfortably. So for sedation, we can use less concentration. We can set the infusion rate at 4 milligrams per kg per hour. And for surgical anesthesia, we can use more dose, and higher plasma concentration will be required. So for pediatric usage, we can use a Pedifuser or Kataria for different age groups. Like Pedifuser, you can use from age 1 to 16, and Kataria only from 3 years onwards. So for if you want to use it for opioids like remifentanil, Minto model is available for fentanyl, Bergman. Similarly, for any other drugs, we have different models. We cannot use the same model for different drugs. So since propofol has no analgesic properties, TEVA is commonly achieved by combining propofol infusion with either regional blocks or with supplemental analgesics, mainly that opioids. So supplemental short-acting opioids here most commonly used is remifentanil, and it is available in the powder form. It has a very short elimination half time, that is 3 to 10 minutes. So it is the drug of choice for TEVA. So depending upon the procedure, like for intubation, we may require 4 to 5 nanograms per ml, and for maintenance, we can use little lesser concentration, lesser dose. For alfentanil, we use Maitri model, and for sufentanil, JEPS model can be used. And this sufentanil tends to accumulate during prolonged infusion, so it is not considered much. So as I told you already, this we have to know, we should know a little bit about the context sensitive half-life. It is the plasma concentration of a drug to decline to 50% after the infusion has been used and we stop the infusion. It usually refers to the duration of the infusion. And so like here, when the drug is fentanyl, alfentanil, and sufentanil are used for a few hours of infusion, for this to reduce the context sensitive half time, it takes a longer time. But here you can see there is a straight line for remifentanil. For how many hours of infusion you use, it is only 3 minutes. So if you don't have TCI pump, how do I use? You can use manual regimes, which is available for both adult and pediatrics. Bristol regime, which we have read long back, it can be used. Initially, you induce the patient with 1 milligram per kg bolus, and then it is followed by 10 milligrams per kg for 10 minutes. You use it for 10 minutes, and then for the next 10 minutes, use 8 and then 6. So these other regimes are also available for pediatric patients, that is Marflan, which is shown here. So some mobile apps are also available like iTEVA and TEVA Manager, which can be used to calculate. And these use PK and PD stimulation program depending upon the mathematical modules, and calculates the dose to achieve the target plasma. You have to set either you want to achieve the plasma concentration or the effect site concentration. So like for less than 3 years age group children, we can use this Stur regime as shown in the table. So what are the indications, special indications? Like with history of, it can be used for almost any case, with history of upper respiratory tract infection, when the inhalational anesthetics can cause irritation, we can consider TEVA. For daycare surgeries, TEVA is best. And for small procedures, you can use bronchoscopy, ENT, laser surgeries, we can use. Even for coronary bypass surgeries, it is said to be safe. One lung ventilation, you can use lobectomy and pneumonectomies, because we are not interfering with the lung for ventilation. And benefits is it separates the provision of anesthesia from ventilation, decreases incidence of PONV. There is nil OT pollution, which is very safe for all the anesthetists and the surgeons who are working in the operation theater. It provides a predictable anesthesia in the shared respiratory cases too. It causes helps in rapid induction and smooth emergence from anesthesia. So patient can be mobilized early and at the same time can be discharged. So it is very useful in daycare surgery cases. And it helps also for the preservation of the hypoxic pulmonary vasoconstriction, that is theoretical improvement in oxidation, which is that theoretical improvement in oxygenation during one lung ventilation. It also said to cause a reduction in the ICP because of the reduction in the cerebral metabolic rate and the blood flow. And main thing which we have to consider is it avoids the systemic toxicity that is related to the inhalational anesthetics when we use it for a longer period of time, that is compound A. So some disadvantages are there, that is initial, it may be little expensive. needs a special sophistication infusion pump, and we need to be trained for the same. Pain on injection, as we it is same with other propofol. Some irritation may cause, and we should know about little bit about the PKPD in for different age group, and the CSHT also varies with that. We have to know little bit about that. The depth of anesthesia monitoring may be required, like BIS, entropy, and EEG. Little bit we need to know about that, and sometimes there may be that lipid load we can think of, and some general principles we have to follow when we are using TIVA. That is checklist as with any other workstation, or we use like checklist. We have to use battery backup, whether it is available or not. Appropriate syringe we need to use. We need to use one-way valve, and we should be especially dedicate one IV cannula for that, and we should not use NIBP monitoring on the same limb, and the site IV injection site, whatever it is, and the connections should be clearly visible. And these are the different infusion pumps that are available for target control infusions, and these should know that the closed loop anesthesia, it has three components, that is brain, effect, and actuator, which calculates the with the components of general anesthesia like hypnosis, analgesia, and neuromuscular block. The variables it calculates and then gives the next infusion. So this is the SED-line spectral density monitoring along with the closed loop TIVA. And recovery is mainly through the redistribution and distribution from the central to peripheral compartment. As the propofol concentration comes down, the awakening occurs, and then at 1.2 micrograms per ml, the patient is fully awake and he's oriented. And we can consider lower propofol concentration when when regional anesthesia or local infiltration is used. And the disadvantages are mainly like as we use for other and the conventional anesthesia, pain on injection can be there. There can be some allergic reactions, and propofol infusion syndrome can be there. That is some amount of rhabdomyolysis and cardiac dysfunction can happen, but it is still not documented yet. And when at all it happens, we have to be careful. We can reduce the lipid load by using 2% propofol, and we should not use it when we come to know about that the patient has a defects in lipid metabolism. So this combination of HFNC and infusion pump is a very good combination because it provides an excellent humidification, humidified oxygen with some amount of carbon dioxide elimination. It allows for safe apnea for a few minutes. And the advantage of TCI is we can titrate the depth of anesthesia towards the polypharmacy, and when the patient recovers, he will be clearly he'll be clear. Why I'm talking about this? Because when we use propofol or for small procedures, we keep on giving so many drugs, like patient is moving like that. So when we use TCI pump, it avoids polypharmacy so that the patient can have a safe recovery and smooth emergence from anesthesia. So this is another closed loop anesthesia model. It is available. Now coming back to the main topic, that is TIVA in ophthalmic anesthesia. Why here? Because extremes of age group we will be handling, and the elderly patients will be coming here with some comorbidities, and because the hemodynamics, there is no much variation, we can consider TIVA for ophthalmic anesthesia. Sometimes the children may come with upper respiratory tract infection, so it is little safe compared to inhalational anesthesia. And most of the patients here are daycare surgeries, so here the smooth emergence and early mobilization and early discharge, so we can consider TIVA. So whenever we think about adults, like general anesthesia is required in ophthalmic anesthesia, ophthalmic cases, because sometimes because of non-cooperativeness of the patient. So we need to give general anesthesia. Some may not cooperate under the trips because they feel claustrophobia. So for these patients, we can consider TIVA. And as I told you before, that is HFNC and some amount sedation. We can set the lower plasma concentration or the effect site concentration, and along with the block, we can safely use stabilize. We can make the patient calm. So in children, as the emergence delirium is more common and laryngospasm is also more common, one can consider TIVA. So in patients coming for strabismus surgery, TIVA is shown to reduce emergency delirium. So we can think of TIVA. So for any other surgeries like surgeries on the retina, cataract, glaucoma and keratoplasty, we can think of TIVA. Along with the block, we can use the lesser concentration. So for examination under anesthesia, as patient requires multiple exposures and children of syndromic babies may have different anomalies, we can think of TIVA. And at the same time, once we are used to it, it minimizes the workload also. So to conclude, TIVA, TCI pumps, that is target control infusion pumps, are probably the vaporizer counterparts of the intravenous agents. That is, initially it is complicated, but once we start using it, it becomes a routine practice, and a little bit of understanding of peak pharmacokinetic and the dynamics of the various anesthetic agents, it will become pharmacological drug administration. So these are my references. Thank you.
Dr. Manjula, one thing I just wanted, some of them have also asked that question.
Yes, sir.
What is your opinion about using TIVA with dexmedetomidine?
Sir, that we have to titrate as per our needs, sir. TIVA can be used with many other drugs. As I said, for analgesia, we are using opioids like fentanyl or remifentanil, and adjuvants, we can use dexmedetomidine, magnesium sulfate. There are so many adjuvants we can use.
Have you done any studies with dexmed?
Sir, for dexmed, we can either use, I don't have studies, sir, but it is recommended that we don't mix the same drug in the same infusion, because every drug has got a different pharmacokinetic model. We can use bolus doses, or you can use separate infusion pumps for the same thing. So when we use adjuncts and analgesics, we can reduce the plasma concentration of the propofol or effect site concentration.
So you mean to say you use propofol and dexmed, okay? You can use a combination of propofol
yes, sir.
and dexmed.
Some are using ketamine and propofol. Some are using dexmedetomidine, ketamine. Some are using different combinations have been used, sir.
Okay.
Thank you, madam. Thank you, sir. It was an excellent discussion. Since we are running short of time, we can proceed to the next topic. Yes, Dr. Parna, you want to add anything?
Yeah, so there was a question regarding dexmedetomidine and propofol TIVA. So I use it for neurosurgery and spine surgery. So in TCI pump, we use propofol, and I use dexmedetomidine in another infusion pump, and fentanyl also in another infusion pump. So TCI requirement, the effect site concentration, lower effect site concentration is required then. So
yes, definitely. Yes,
we can use it, and I've been using it very, very regularly.
Yeah.
And madam, I wanted to know what kind of ophthalmic cases you are using it for, TCI.
No,
propofol.
actually, the TCI is less used till now. Even I have also learned recently only after the workshop, but it is very helpful. So as I said, there are, because our ophthalmic cases are day case surgeries, so it is very useful because they have less emergent, safe recovery and early mobilization, and they don't have other complications, so they can be discharged well in advance. And strabismus, it is very much indicated. And when we some retina surgery, some cataract surgery, they sometimes call because the patient is now unable to lie down under the drape. So for those patients, we can reduce the concentration of the plasma, and then we can use, say, infusion pumps, so that the apnea problem also can be taken care of.
Okay, but you are not using it regularly.
No.
Well, doctor,
Okay.
we are
Okay.
using very regularly for strabismus surgeries
Okay.
because many of
Okay.
the squint surgeries they do so fast. By the time, instead of giving a muscle relaxant and all, we almost use, but we are not using the pumps and all which Dr. Manjula have mentioned. But we use something like Tiva, and within 5-6 minutes they do one muscle, and within 10 minutes they do the two muscles. So instead of paralyzing the patient and all, we normally use this type of anesthesia, putting an LMA and putting the
Okay.
patient on spontaneous, with taking them deep into with this Tiva concentration.
Okay. You use ketamine also, sir, with that?
No,
Or
ketamine
just
we
the
are not.
block and
We
propofol?
are not using, but many
Okay.
places they are using ketamine.
Okay.
Many
Okay.
places they are using ketamine.
Okay, sir. Thank you. Thank
Strabismus,
you, ma'am. Thank you.
may
Thank
I answer
you.
your question? It's strabismus surgery. There is no need giving any Tiva or sedation for that. But only thing is you give the block properly so that the patient does not have the oculocardiac reflex during the medial
Sir, this
access
is
muscle.
I'm talking about where the block is not given at all. There is no block. Suppose a 3-4 year child is there, a squint surgery. So for that type of patients, I am using without
Okay.
paralyzing. I'm talking about those patients. Not about the blocks. Block is apart from block. If you want to give Tiva, that is separate. There is a different.
No. Along with the block, not Tiva.
No, not block at all. No, only
Okay.
Tiva. Only Tiva.
Okay. No, we are not using Tiva.
Thank you.
Thank you, ma'am. We'll move to the next topic. Thank you. We'll move to the next and the last topic, which is pediatric ophthalm, general anesthesia. And the pediatric ophthalm cases are different, as the children with eye problems, they present with certain syndromes and other problems. To talk about this important topic, we have Dr. Reena Gautam, a very dynamic anesthesiologist practicing as a consultant anesthetist for last 20 years in Thane and Navi Mumbai. And she's attached to Advanced Eye Hospital, Navi Mumbai, Bachu Ali Hospital in Mumbai, and National Eye Center, Thane. She's been Secretary General and council member of ISA Navi Mumbai. Welcome, Dr. Reena. You can start your presentation.
Thank you, Anjali, for that kind introduction. Am I audible?
Yes, we can hear you.
Okay. So I'll be talking on anesthesia for pediatric ophthalmic surgeries. Before that, I would like to thank Manisha ma'am and Thane Anesthesia Society for giving me this opportunity. So this is my attempt to compile the unique anesthetic considerations aiming to provide optimal perioperative care for the pediatric patients in ophthalmic surgeries. So in these 20 minutes, I'll just be talking about some common syndromes in eye surgery patients, common ophthalmic surgeries in pediatric patients, and some very simple tips and tricks which I am using in my daily practice. So majority of pediatric patients undergoing eye surgeries are healthy ASA grade 1 and 2 patients who are managed as daycare surgeries. But some of them may have underlying disorders which may pose anesthetic challenges, and a number of syndromes in which there can be major difficulties can be associated with cataracts, glaucoma, and squint surgeries. So to start with congenital rubella syndrome, it is seen in babies who are born to mothers who are infected with rubella. And it's known to be associated with congenital cataract and congenital cardiac defects such as patent ductus arteriosus, pulmonary stenosis, ASD, atrial stenosis, right ventricular hypertrophy. Along with this, they have multisystem abnormalities, which can be delayed milestones, microcephaly, mental retardation, unanticipated airway abnormalities. I'll not discuss the routine lab which we do investigations and the routine anesthesia things, just to highlight the major major anesthetic changes. You have to take care of the decrease in the peripheral vascular resistance, avoid tachycardia and myocardial depression, systemic hypertension, maintenance of sinus rhythm and intravascular volume with awareness of potential myocardial ischemia. Down syndrome, this is the commonest chromosomal abnormality seen, and it is a genetic disorder caused by presence of whole or a portion of third chromosome 21. And the eye abnormalities include cataracts, strabismus, nystagmus, retinal abnormalities, glaucoma, nasolacrimal duct obstruction. Airway anomalies can be present. It can pose difficult airway, so it's always better to keep all the smaller size endotracheal tube ready, as there are chances of subglottic stenosis. These patients can have unstable cervical spine, so positioning has to be taken care even while laryngoscopy. Care has to be taken while manipulating the neck. Cardiac anomalies associated are atrioventricular septal defects, patent ductus arteriosus, tetralogy of palate. You have to maintain the systemic vascular resistance, peripheral vascular resistance. These children can have mental retardation, obesity, hypotonia. The common complications seen in Down syndrome are bradycardia, airway obstruction, postoperative apnea. This is very common. I had a patient where twice or thrice the patient had gone into postoperative apnea. I had to monitor the patient for roughly 3 to 4 hours, and I had put a nasopharyngeal airway. So postoperative monitoring is very important for these patients. Marfan syndrome is an autosomal dominant disease with defective gene FB1 of the connective tissue, and it involves skeletal, cardiorespiratory, and ocular abnormalities. Skeletal abnormalities, these patients are generally tall, upper body is shorter than the lower part. They present with kyphoscoliosis, arachnodactyly, joint laxity, scoliosis, space planus, space excavatum. Cardiac anomalies, commonest is the dilatation of the aortic root and ascending aortic aneurysm. There is a deposition of mucopolysaccharides, which restricts the expansibility of the aorta. The dissection of aortic aneurysm was the commonest cause of death in such patients. But nowadays, with improved surgical techniques, this has been treated and can be avoided. There can be mitral valve prolapse, mitral regurgitation, ophthalmic presentation. The commonest is the lens subluxation, glaucoma, increased axial length of the globe, history of obstructive sleep apnea, pneumothorax. There can be dural ectasia. Anesthetic management, you have to take care to decrease the aortic pressure, have closed hemodynamic monitoring, maintain blood pressure, intravascular volume, minimize intubation response, and careful positioning. There are many other syndromes associated with these ophthalmic conditions, craniosynostosis, craniofacial abnormalities like Treacher-Collins, Goldenhar syndrome, mucopolysaccharidosis, Edwards syndrome. The hallmark of this is you have to be prepared for difficult airway, accordingly manage the cardiac conditions and the cervical instability. There can be neurocutaneous syndromes, homocystinuria, Stickler syndrome, Hallermann-Streiff syndrome. In homocystinuria, you have to take care that there can be thromboembolic events. Otherwise, again, difficult airway is the commonest thing in all these syndromes. Neonates, obviously, they have their own set of anesthetic considerations. Congenital cataracts, ROP, retinal detachments are seen in this. So you have to take care of the glucose control, temperature management, postoperative apnea, and bronchopulmonary dysplasia. Now coming to the ophthalmic surgeries, strabismus is the commonest ophthalmic surgery in pediatric patients. It is the ocular misalignment which leads to loss of binocular vision and amblyopia. The presentation is usually 1 to 4 years. Depending on the surgeries done, A muscle recession, where the muscle action is weakened. In resection, there is strengthening of the muscle action. In transposition, the muscle action is used to produce a new action. Now, most of the children are ASA grade 1 and 2, but again, as told before, there can be some chromosomal metabolic abnormalities and also neurological disorders. Commonly seen palsy, meningomyelocele, seizure disorders. So clinical assessment, you have to take care. History taking is. Hello?
Yes, Reena, we can hear you.
Can you hear me? My
Yes,
internet
Reena.
connection is proper?
Yes, we can hear you.
Okay, thank you. So there can be prematurity. The prematurity is one of the etiological causes of strabismus. So you have to again ask for the history of any Halm membrane disease, neonatal seizures, sepsis, or developmental milestones delays. There can be associated some congenital heart diseases, seizures. You have to ask for any family problems, which can clue of muscle movement was associated with malignant hyperthermia. The recent studies shows that the correlation is no longer considered very strong association, but there are chances of tight jaw or masseter spasm in this patients. Then you have to ask for any history of postoperative nausea, vomiting, motion sickness. Again, URTI for this age group, it is very common and you have to assess accordingly. Loose teeth, dentition, it is always better to ask if there is any loose teeth and tell the parents that during there can be chances if the teeth is very loose during laryngoscopy. If it is very loose, it can get detached. Now, oculocardiac reflex, it's defined as 20% decrease in heart rate from the baseline, dysrhythmias or sinoatrial arrest associated with ocular muscle traction. Aruna ma'am has told us the pathways, so I'll not go in detail. In children, this is common because of their high vagal tone. So always a pre-filled syringe of atropine should be readily available. And this reflex is fatigable. So always it's the first muscle which gives the biggest response. It is more common in patients where there is high PaCO2, more than 40 millimeter mercury. Also in cases where previously when halothane was used, this used to be more common. Now PONV, postoperative nausea vomiting, is a commonest, is more common after strabismus surgeries. During the squint surgeries, impulses from the extraocular muscles are related to the vestibular nuclei 3, 4, and 5 of the medial longitudinal fascicula, which lie in the brainstem reticular formation. Now, these nuclei are in close proximity of the vomiting center, and impulses in the former may stimulate the vomiting center. To support this theory comes the fact that there is association between oculocardiac reflex and subsequent postoperative nausea vomiting. The children who had oculocardiac reflex are 2 times, 6 times more likely to have postoperative nausea vomiting. Again, the surgical technique of myopexy, where the posterior fixation of the muscle is done. In such cases, because of the sustained stimulation, the incidence of postoperative nausea vomiting is high. Again, volatile agents, opioids, they can also be a factor for postoperative nausea vomiting. Now, for prevention of this, the Association of Pediatric Anesthetists of Great Britain and Ireland had updated the guidance on PONV in 2016. The recommendations include liberal intraoperative fluids of 10 to 15 ml per kg, dual therapy with ondansetron and dexamethasone, which drastically decreases the incidence of postoperative nausea vomiting. Also, subtenance block during or after surgery, when the surgeon has already opened the muscle sheath, deposition of small amount of local anesthetic can help to reduce the incidence of postoperative nausea vomiting and also take care of the pain, postoperative pain. Nowadays, surgical squint surgeries, surgeons use adjustable sutures That is, they can adjust the amount of recession or resection afterwards. This gives them an opportunity to titrate the results, especially in patients where the results are unpredictable. Now, depending on the procedure, and here I would say also on the speed of the surgeon, our anesthesia may vary. Sometimes it just takes 2 minutes to either tighten or loosen the suture. For such cases, I do on mask with inhalation anesthesia. Otherwise, we can use STIVA or GA with LMA according to the time taken for the surgery. Cataract surgery. Cataracts in children are common, and if untreated, it can lead to blindness. So it is advisable to the surgery to be done as at the earliest. Now, cataracts can be inherited as autosomal dominant or can be parts of syndromes or acquired after trauma or infection. Bilateral cataracts are mostly associated with systemic diseases, whereas unilateral cataracts are most often idiopathic. Now, the preoperative assessment and preparation. Here we have to deal for congenital cataracts. We need to take care of the vulnerable premature infants born with congenital disorders. In infants and older children, in addition to the medical condition, we need to assess the psychological status of the child, allaying anxiety of the child as well as the patients. And in children, the cataract again interferes not only with the visual acuity, but normal brain development. So cataract is considered as an urgent surgery. Again, birth history is important. Important if there is a prolonged history of prolonged neonatal care, you have to consider the possibility of subglottic stenosis, apnea, bradycardia episodes, and additional oxygen requirements. In such patients, you have to take care of the glucose supplementation in newborns and infants to maintain normoglycemia. And the cataract surgery demands a motionless eye, smooth induction and emergence to avoid intraocular pressure rise. Also, controlled ventilation is preferred to avoid hypocapnia. I usually prefer to use endotracheal tube for the cataracts, which so that because again airway access is restricted during the surgery. But again, supraglottic devices can be used nowadays. PONV is again common in cataracts, and dual therapy is advisable to decrease the incidence of postoperative nausea vomiting. Now, examination under anesthesia is necessary in children under anesthesia because of they can be uncooperative because of their age, developmental delay, or extreme anxiety. Now, ophthalmic examination includes measurement of the corneal diameter. This is the picture showing where I had done the EU under LMA. The corneal diameter is being measured. There can be, you need to do direct or indirect fundoscopy may be needed, refraction, IOP measurement, traction test for strabismus. All this is included for examination under anesthesia. Now, face masks or supraglottic devices can be used. You can choose between inhalational anesthesia or intravenous induction. Now, depending on the expected time taken, pain and discomfort is expected when there is rotation of the eye for fundoscopy and muscle traction for the strabismus evaluation. IOP measurement is required for important for diagnosis and management of children with glaucoma. So it is essential to provide the anesthesia technique, same technique if they have come for repeated IOP measurement. Here, alteration of about 2 millimeter mercury is tolerable. Now, in addition to glaucoma, patients of retinoblastoma also can come for repeated EUAs. This can be to see the effect of the chemotherapy or treatment given, or just as a follow-up to see if there is no recurrence of the retinoblastoma. And you have to be careful that when dark environment is used for the fundus examination, we have to be vigilant in such conditions to carefully watch the spontaneous respiration and reservoir bag movement. ETCO2 tracing in such times is very helpful. Now, these are the anesthetic drugs effects on the IOP. Or usually all the induction agents, they lower the IOP except ketamine. But again, the recent study shows ketamine, the effect, it increases the IOP usually if it is more than 5 milligram per kg, used more than 5 milligram per kg. In lower doses, usually the IOP remains as in awake state. Non-depolarizing muscle relaxants have minimal effect, but again, saxamethonium can increase the IOP for up to 8 millimeter mercury for around 10 minutes. Volatile anesthetics, they lower the IOP. Nitrous oxide doesn't have much effect, but again, it is contraindicated in presence of intraocular gas. Opioids have minimal effect. Ondansetron, they don't have any effect on the IOP. Now, probing and syringing. I feel this is the trickiest procedure amongst all the ophthalmic surgeries. As it's even though it's a short procedure, we are sharing airway with the surgeon. So it is safer to go with endotracheal tube intubation with a throat pack. But again, supraglottic devices can be used. And the manipulation of inferior turbinate is usually required. And this can lead to bleeding. So proper preparation with Otrivin nasal drops has to be done. Intraoperative suctioning of the nostrils, nasopharynx is required to remove the saline or blood before extubation. Again, you have to be vigilant to see if the OT staff has used saline to dilute the fluorescent dye, because sometimes they use even distilled water. So saline is better in case there are any trickle in the trachea. Glaucoma, again, there is progressive damage of the optic nerve, which is caused by the increased intraocular pressure. In children, the mechanism is mostly due to reduced drainage of the aqueous humor. And most cases are congenital and they result from the failure of development of the trabecular drainage network. In these patients, cornea is cloudy, photophobia is common. These patients can come to us for trabeculectomy or implantation of drainage devices. Commonly used is Ahmed valve. So for anesthesia, general anesthesia, the key factor is consideration to the blood flow to the optic nerve and perioperative intraocular pressure maintenance and avoidance of postoperative nausea, vomiting. Now, the ocular nerve head blood supply is often impaired in this patient. So, systemic hypertension has to be avoided. And in case of postoperative nausea, vomiting, there can be choroidal hemorrhage, which can lead to visual loss. Coming to retinopathy of prematurity. Now, it is a vasoproliferative retinal disorder due to arrest of the normal retinal neovascular development, followed by compensatory aberrant vascularization in preterm neonates. It can be treated by laser ablation therapy. There has to be consideration for the stress response with cardiopulmonary implications during laser ablation, during scleral indentation, deep retinal burns, or manipulation of the globe. There is considerable variability for anesthesia and sedation practices at various centers. Some places it's done in operation theater, somewhere in ICUs. Now, the Cochrane review has reported that topical proparacaine can significantly reduce the pain scores for speculum insertions in these preterm neonates. Oral sucrose with or without non-nutritive sucking can be helpful to reduce the pain. Again, protective goggles have to be used by the anesthetist, surgeon, and the staff holding the pediatric patient. Now, these retinopathy of prematurity, which cannot be managed or controlled with diode laser ablation, they have to be taken for vitreoretinal surgeries. The concerns in this preterm infants, I have used the table from our book, Principles and Practice of Ophthalmic Anesthesia. Now, the respiratory system, there is poor compliance, increased oxygen requirement, obstructive airway pattern. Cardiovascular system, there can be left to right shunt progressing to heart failure. You have to take care of, there should be no reversal of shunt. Again, air bubbles can lead to embolism. So extreme care has to be taken. CNS, there can be chances of intraventricular hemorrhage. So tachycardia, hypertension, rapid fluid shift have to be avoided. Renal significance, there is immaturity of the tubular function. So it is important as there can be risk of acidosis, hyponatremia. Temperature management is also important. You have to avoid hypothermia. Glucose homeostasis, again, even hypoglycemia, hyperglycemia has to be avoided. Now in this vitreoretinal surgeries, we need constant vigilance and rapid intervention. Anemia is a concern in neonates. Care has to be taken to maintain the ambient temperature in the OT. High airway pressures have to be avoided to prevent shunt reversal. Nasogastric tube is usually put because any small amount of gastric inflation can hamper the expansion of lungs. Good analgesia and has to be given, and again proper monitoring in view of risk of postoperative apnea has to be taken care of. Now, retinoblastoma is a common malignant tumor occurring in the retinal cells. It is the commonest primary intraocular malignancy in children. It presents with leukocoria, where the pupil reflects light abnormally as a white reflex. The treatment includes eye-preserving therapies, which include photocoagulation, cryocoagulation, chemotherapy, and in advanced cases where to prevent the metastasis, the child can be taken for enucleation. Now, anesthesia concerns for enucleation. There are high chances of oculocardiac reflex during enucleation. There are chances of bleeding, and you have to take care that to avoid cuffing on the endotracheal tube. Again, it will give rise to the oozing. These patients again can come for repeated anesthesia, for examination under anesthesia to see the treatment, how it is working, chemotherapy, or again to confirm if there is no recurrence of retinoblastoma. Now, after this, I will come to some tips and tricks. Befriending a pediatric patient avoids crying and decreases the anxiety, which helps a lot for smooth induction. Now, being a private practitioner, I didn't have the luxury of sevoflurane in all the setups where I go, especially a few years back. Now the conditions are changing. So over the years, I have been using some simple tricks to help bond with the patient, and so that the child readily accompanies you in the operation theater. I have taken consent from these patients for using their photographs. Now, based on the overseas concept of flavored mask, I keep some flavors of edible essence like vanilla, strawberry, chocolate in the operation theater. We ask the child which flavor they prefer, and then smear the mask, face mask, with a few drops of this, and we give it to the child, that mask, to play in the waiting area. Then the child is comfortable with the mask for inhalational induction. In our preoperative assessment, just talking to the patient, knowing what they like, can be very helpful. Now, this was a playful child who liked maths. So he was very fascinated with the idea when I told her we have a TV in our operation theater where you will get the numbers, see the numbers. So here he is eagerly waiting to know what is his blood pressure. And he also agreed later nicely for mask counting for the induction without crying. Also, I use the stickers, like the stars and smiley stickers on the IV stickings. These stickers are shown to them in the recovery room, and we tell them that if you don't cry, you will get 5 stickers of your choice. And many of the children, they are really happy for this. This is the patient who was busy selecting his favorite color after taking the IV line. He really didn't cry at all. Not that all patients don't cry, but many of them, it's helpful for them. Initially, when I started, I just started with simple stars drawn with pen. Intranasal midazolam also works well to allay the anxiety before induction. This child allowed the needle prick for securing the IV line. Difficult IV access is very common in chubby children. So I use this LED torch over the palmar surface of the patient, and it gives a nice view of the veins on the dorsal aspect. It is beneficial. It avoids multiple punctures. Only thing is you need one extra OT staff to switch off and switch on the lights where you see these veins in dark. Also, we had some months we had kept some small soft toys in our operation theater for the children to accompany them to the operation theater as OT buddies. Nowadays, mobile phones are readily available where you can distract them with their favorite cartoon characters. And now in basically some years back when LMS were not easily available, I used to use this technique to tie a mask on the face for small procedures like examination under anesthesia or 1 or 2 muscle squint surgeries, where the mask was nicely used to hold on the face, and the face mask, cloth face mask is placed below the head of the patient and nicely tied. It is very useful, especially in EUS where you don't want your hand holding this and changing the IOP and all. This is helpful. Again, corneal drying and abrasions. They are very common if usually one surgery that eye is taken care of, but the other eye can sometimes remain half open and may not close completely. So it is better to tape this eye. This can also be practiced in all non-ophthalmic surgeries to protect the delicate cornea. Now, for all my intubated patients, I use uncuffed tubes with a throat pack. This helps by absorbing the collected secretions in the oropharynx and decrease the use of suction and resulting trauma. Again, production of artificial cuff by applying positive pressure just before extubation to expel the subglottic secretion. I use this, and studies have shown that there is decreased incidence of laryngospasm because it decreases the adductor response of the laryngeal muscle. Just as we tell our adult patients to take deep breath before while extubation, this works as the same way. Now in the syringing probing, it is before extubation, thorough suctioning is advisable. Also in oculoplastic cases, sometimes there can be collected blood clots behind the uvula. So it is advisable to wipe the nasopharynx with a folded small gauze piece with our magils, and many times nice 1 or 2 big chunks of the clots, especially in oculoplasty or when in probing, if there is more bleeding, you get these clots. So it is helpful because it avoids the postoperative irritation or cuffing of the patient. Also, when the surgeons need to confirm the fluorescent mixed saline reaching the nasopharynx, the quality, I have zoomed the image. Here you can, I usually use a gauze piece. If you can see, I have a gauze piece behind the nasopharynx, behind the suction catheter. So here you can easily confirm when the fluorescence is not seen, it is blood stained. It is the mixture, the fluorescence is easily seen if the background is white. So all these are very simple tricks, but they really help a lot. My references, these are my references and my email ID. And thank you.
Thank you, Dr. Reena. It was indeed a great presentation. Very nice practical tips and tricks discussed and many takeaway points. One question from the chat box. Any preferences for endotracheal tube or LMA, and any one of us using dexmedetomidine intranasal spray for pre-medication for children? Are you using Dexmed for intranasal?
No, Dexmed I'm not using intranasal.
Actually, many of them have started using intranasal Dexmed, 2 mics per kg.
No, sir, it is 1 mic or 0.5.
Yeah, 1 to 2 mics, depending on the.
No, no, sir, two will be little more, but you can use 0.5 to 1.5 milligrams, micrograms per kg.
Okay, 1.5, or some of them are using 2 also. So the only thing is you should have a good preoperative area nursing staff and all, because they may land up in some complications. So somebody should be watching them. If not, it is a very useful drug which can be used
Yes, it is
pre-operative.
very useful, but at the same time, we need to monitor the child
Monitor it
in the
thoroughly.
pre-op. And it is very useful even for the parent separation also. Like, we can easily take the patient away from the parent once the child is under dexmedetomidine.
Yeah, separating from the mother is also useful. Nowadays, we see in our hospitals so many children crying there, and when they are separated from the mother, and also to avoid that, I think this may be a good, but only thing is nursing should be, it's very difficult to have so much of manpower and all to see the pre-op area, good nursing staff who can monitor the pediatric patients so well.
Thank you. Thank you so much, everyone. With this, we conclude the scientific session, and I request Dr. Nilima to propose a vote of thanks.
Thank you, Anjali. So we are coming to the end of today's webinar. Dr. Vavikar, sir, do you have any comments or should we conclude it?
Thank you very much. It was a really excellent seminar from our point of view also.
Okay, sir. Thank you so much for joining. Thank you, Thane ISA, for bringing us this superb webinar, especially as a part of World Anesthesia Week celebration. Thank you, Dr. Manisha Ghosh, President, Dr. Parna Thakkar, Secretary, and Dr. Sunil Katkade, sir, Founder President of Thane ISA and Governing Council. Thank you, SAM's office bearers. Thank you so much, Chairman Dr. Chandrasekhar Vavikar, sir, for his valuable insights. Thank you, Dr. Vaishali Vavikar, madam, for release of our 8th edition of e-bulletin, Samvedana. It is done very aesthetically and you all will enjoy reading it. Thank you so much, our speakers for today, Dr. S.C. Parak, sir, Dr. Manjula, madam, Dr. Aruna Gaitonde, madam, and Dr. Reena Gautam, madam, for a very comprehensive presentation. Thank you, Dr. Anjali Nair, our moderator for today. It is a pleasure working with Anjali because she cannot rest until all small issues are resolved. Thank you so much, Mr. Ganesh, from Jenica Technology for all the technical support. And last but not the least, thank you all the delegates for joining today's webinar. Thank you so much.
Thank you very much.
Thank you very
For
much.
bringing
Bye,
us there.
everyone.
Thank you so
very
much.
Thank you. Actually, going by the discussion that is going on, I think a part 2 of this ophthalm and anesthesia is highly needed. What do you think, Nilima?
Yes.
Actually, I invite you all. Sorry for the interruption, but I think you should all join our association, and I think everybody will be benefited. So a lot of discussions will be happening there. So India Association of Ophthalmic Anesthesiologists.
Manisha, we can have surgery workshop also.
Which one?
Yeah. We can have live surgery and anesthesia workshop.
Yes, definitely.
Yeah.
That will be a pleasure. We have a very good setup and we can do live relays and it will be really great.
Yes, sure.
Yeah.
Initially, I think we were a little skeptical about this because we have not done ophthalmic this thing webinar before. But looking at the response, I think, Manisha, we can have part 2.
Yeah, definitely. Thank you very much, everybody, for joining in. And I want to specially thank Dr. RNR and Dr. Renu, who took an active discussion and made the webinar even more lively and interactive.
Okay, thank you. Happy
Thank you,
World
everybody.
to everybody.
And good night.
Thank you.
Thank you.
Thank you all. Bye. Good night.
Yes.
Bye.
मीटिंग एंड करूँ का